Thank you so much, everybody, for joining me and Dr. Salvo tonight. I will do a quick intro for him, go over a little bit of housekeeping, and then we'll get started. So if this is your first time, welcome. When we get to the end of the presentation, Dr. Salvo will speak probably about 20 minutes, 20 to 30 minutes, and then we will do a Q&A session at the end. There's a box, if you look towards the bottom of your Zoom screen, that says Q&A, not the chat box, the Q&A box. If you have any questions, pop them in there. We will go over them at the end. We do ask that you keep the questions kind of general and not related to your specific case or your specific issues, just something that everybody would be able to relate to. I will also put in the chat box my contact information. So if you have any specific questions or you'd like to schedule an appointment with Dr. Salvo, you can call, text, or email me, and I can get you set up with that. I think that's the housekeeping. So let me do a quick intro and then he can get started. Just a moment. Okay, so Dr. John Salvo is a double board certified orthopedic surgery and sports medicine a surgeon. He specializes in sports injuries, knee ligament reconstruction, meniscus tears, shoulder instability, rotator cuff repairs, and hip arthroscopy. He is the director of the hip arthroscopy program at Rothman Orthopaedics and one of the region's leaders in it's going to get me every time, isn't it? Hip arthroscopy and hip preservation, particularly in athletes. He is a consultant for the Philadelphia Phillies and previously served as the team physician for the Philadelphia Eagles, as well as the Philadelphia Flyers. He's a professor of orthopedic surgery at the Sidney Kimmel Medical College at Thomas Jefferson University Hospital and is an active member of several subspecialty societies. He sees patients in our Marlton, New Jersey office, as well as our Washington Township office. And that's all I have. Go ahead, Dr. Salvo.
All right. Thank you, Kristen. Thank you for organizing this and welcome everybody virtually. I'm going to see if I can get my slideshow up here. So tonight we're going to be talking about ACL injuries and treatments and ACL reconstruction and the current concepts about the latest and greatest and what works the best and how we really kind of approach these injuries, which can be unfortunately devastating to young athletes, especially high school collegiate athletes, and then even weekend warriors as we're getting further on in our lives when you have this type of injury. I am a consultant for Stryker Endoscopy, has no bearing on this talk. So some of the controversies that we deal with ACL tears, one is prevention, and it's a big topic that's been looked at over decades about how do we possibly prevent these type of injuries. Once they have the injury, typically if somebody tears their ACL and they're young and active, and especially in athletes, it's going to need to be fixed surgically in order to stabilize the knee. So the first thing I'm going to do is go through some anatomy slides so everybody kind of knows what we're talking about here. And then kind of go through what happens with these injuries and the things that we consider in treating these athletes that have this type of injury to their knee. We're going to talk about some techniques for the reconstruction. We'll talk about briefly just about choices of grafts. And then another important topic is return to play. So once they have this injury, they get treated, they go through all the rehab. When is it safe for them to go back to their sport? So with knee injuries, there's almost 5 million people annually that visit orthopedic surgeons' offices because of knee problems. About 3 million of these are directly related to an injury. Another almost 1.5 go to a hospital or an urgent care for knee problems. And obviously most of those are due to an injury because of the acuteness of those centers. So the ACL is the anterior cruciate ligament. So it originates from the shin bone, which is seen here. So this is a cutout as if the thigh bone is taken away. This is the outside or lateral. This is the inside or medial. The front is the ACL, that's the anterior cruciate ligament. So on the tibia or shin bone, it starts basically in the middle towards the front of the knee. And then the PCL is a ligament in the back, and there's a couple of ligaments on the sides. This picture might show it a little bit better. This is looking from the front. This is a right knee. This is your kneecap. This is the outside. This is a little bone called the fibula. This is the inside part. The meniscus or the shock absorbers of the knee, we're really not going to touch too much on that. But this is your ACL, so it comes from the middle and the front, and it goes in the back to the outside or lateral part of your femur or thigh bone. So that is the main stabilizer in the middle of the knee. There are a bunch of other structures around the knee that we can touch on. This is a little too busy to really hop into, but this kind of really shows where the ACL is. So what the ACL does is it keeps the shin bone from going forward relative to your thigh bone in the knee joint. So the knee joint is where your thigh bone meets your shin bone. So the ACL prevents it from going straight to the front, and also provides a lot of rotational stability to the knee. So this is an arthroscopic picture of a normal ACL. So this is the ACL in the front. That's the cartilage from the thigh bone. Shin bone is down here. It actually has two bundles to it. You can actually see it pretty clearly in this. So they actually rotate together. So one bundle's like this and one bundle's like that. And they really rotate on each other depending on the position of the knee and where they are, whether you're going straight or whether you're rotating. And they just provide all that tightness to the knee. So it's a primary restraint to limit anterior tibial displacement. It's strongest at 30 degrees. Secondary restraint to rotation, and that's greatest at full extension or full straightening of the knee. And it also does give some side-to-side stability, what we call varus and valgus, which is moving the shin bone either to the inside or the outside. So it's kind of a backup for that. So there are a tremendous number of ACL injuries that happen every year. There's about 200,000 ACL injuries in adults annually. 70% or a little bit more are from non-contact injuries. So they're not always typically a contact injury. They're usually non-contact. The highest incidence is in 15 to 25-year-olds who are participating in cutting and twisting sports, what we call the level 1 and 2 sports. So those are soccer, lacrosse, football, basketball, sports like that. The incidence in older people and in younger ages has been increasing over decades, because you think about it, sports participation is younger, and they start younger and younger, and they get super specialized into a single sport at a younger and younger age. And over time, these kids are really putting a lot of miles on their knee that we usually wouldn't see until their late 20s or 30s, because of all the practices they do, all the tournaments that they do, all the clubs that they participate in. It's just repetition after repetition after repetition. So the incidence of these injuries is going up. But the vast majority are non-contact injuries. So a typical history from a patient is that they were running, they planted their leg and tried to turn, and they felt a click or pop in the knee, and then had swelling, and then had pain. That is a typical history. Not every ACL is injured that way, but when we see somebody in the office who comes in and says they had felt a click in their knee or pop in the knee as they were changing directions, and then their knee swelled up, the first three things we're thinking about is they possibly tore their anterior cruciate ligament. So there's over 200,000 annual ACL reconstructions in the United States. Again, most are from non-contact injuries. Almost all are pivoting injuries. Now, contact injuries can be higher risk for damaging some of the other structures around the knee, but the non-contact injuries with the ACL are typical, but they can happen with contact as well. So the vast majority are going to occur in the active age group, so 15 to 45-year-olds, which is about half the population of the United States. Annual incidence is one in 1,750 people. When you're looking at female athletes versus male athletes, females have a 2 to 10 times greater likelihood of an ACL injury than men that are playing the same sport. So we're talking about high school soccer, men's versus women, high school basketball, men versus women, lacrosse, men versus women. So you have that population. And when we look back at this and look in our literature, there's a much higher incidence of females having an ACL injury than males. Overall, there are more total ACL injuries in male athletes than female athletes. That's just because tends to be more male athletes participating than female athletes. But when we look at that controlled population, it's a much higher risk in females, and there's many reasons for that. So what are some of the risk factors when we're thinking about why are people tearing their ACLs? Why is the frequency increasing? Broke them down to basically four categories: environmental, anatomic, hormonal, and biomechanical. So environmental are all like outside factors. It can be cleat use. It can be, the number of practices you're doing, the weather conditions. Is it slippery? Is it snowy? What are the floor conditions in basketball? Anatomic has to do with the structures of the knee and the difference typically between a female athlete and a male athlete. Some of the differences: the hamstrings react a little bit slower in female athletes versus male athletes. They are a little bit weaker in female athletes than male athletes, and that's critical because your hamstrings are your dynamic stabilizers and backup for your ACL. They help protect it. Hormonal factors, that's still controversial. There are some studies that have shown progesterone and estrogen receptors on the ACL, and that can affect the elasticity of that ligament. But it's really a mishmash of the data that's out there. There might be something there, but there's not anything we can nail down and say, hey, this is a problem that we need, so we can control it. And biomechanical is really landing mechanics, how people land when they jump and they pivot, their muscle control between their glutes, their hamstrings, their quads, and how their knee is moving in space. So environmental can be shoes, playing surface. Higher friction with shoes on a surface can lead to increased incidence of knee injuries. We knew that back in the 80s and the old turf days with turf shoes. They were way too much friction, and there were a higher incidence of ACL injuries at that point. Fatigue is certainly a factor, and then weather conditions. The anatomic, the width of the notch, which is where the ACL lives. So if you have a narrow notch, you have less space, you have more stress on the ACL. A valgus knee, which is really a knocked knee. So most knees are straight. So a valgus knee is kind of, if this is the thigh bone, it's like this, and a varus knee is the other way, or bow-legged. So the knock knees are the ones that actually your knee is in a vulnerable position to damage your ACL. We see that more in female athletes versus male athletes because wider pelvis, higher incidence of that knock knee, and it affects your landing mechanics. So that's what's critical, because when these athletes are performing and they're planting and turning and rotating, we want that knee straight when they're planting. We don't want it in the knock knee position. We don't want it rotated, because that puts the ACL at risk for injury. So biomechanical, landing, a valgus landing and internal rotation puts your ACL at risk. The muscular imbalance, if the quads are stronger than the hamstrings, or the glutes aren't working with the quads and the hamstrings, it can put you in a vulnerable position when you're playing these pivoting, cutting, twisting sports. And like I had mentioned before, just we're talking nanosecond delayed reaction for the hamstrings, which protect your ACL. They're dynamic stabilizers, and that can actually put your ACL at risk as well. So how can we prevent ACL injuries? So we know there's four categories of risk factors. So we take ones that we can modify and may be variable, and then there are some that we can't modify. So how do you prevent them? Nobody plays sports. That's not going to happen. So it's really impossible to prevent ACL injuries. I mean, they're going to happen. It's a risk with athletes. You may be able to identify the at-risk athlete and decrease the incidence of some of these ACL injuries. So the environmental factors, they're variable. If it's variable, we can adjust it. Anatomic, you can't change. Your anatomy is your anatomy. Hormonal, you can't change. Your physiology is your physiology. Biomechanical, that's variable. There are things there that we can change. And there are some ACL prevention programs that can really address these issues and may decrease the risk for an injury. But we also use those programs when people have had an ACL reconstruction as they're getting ready to return to play. So we can identify any of those biomechanical factors that may put the ACL at risk for re-injuries, because that's the last thing that we want. So when we have a patient that comes in, we're suspicious, we always do a history, ask them how they got hurt, when they got hurt, did they swell up, any problems with the knee before this. We do a physical exam. If it's early on, within a few days or a week, they're usually coming in swollen. They're on crutches. And then we got to examine them. Sometimes we need to take that fluid out of the knee too to make them more comfortable. And then radiographic studies. We always get x-rays. if we're dealing with 13-year-olds, 14-year-olds, then you're considering whether the growth plates are open or closed or closing, making sure there's no fractures and looking at the alignment. And then, of course, an MRI, which really shows us everything inside the knee. The x-rays just show us the bones and the growth plates. The MRI shows us the meniscus, the ACL, the cartilage, everything that we need to see. So we kind of put it together. So this is just a picture from the operating room. This is somebody who tore their ACL. So this is where their knee is sitting just naturally for this patient. And then that's translating anteriorly. So this person tore their ACL, and that's why it's loose. That's our best test. It's called the Lockman test. So it's about 20 degrees or 30 degrees of flexion, anterior translation. If it translates, then you're likely damaged your ACL. Very reliable test to do also in the office, but you really have to get them to relax their hamstrings to get a good clinical exam, because if they tighten up the hamstrings, you may miss an ACL tear clinically in the office. So we get x-rays, same standard set of x-rays, looking at the growth plates, looking at the alignment. MRI is very accurate, but it can depend on the sequences they use, but they are so good now. The only ones that I don't like are open MRIs or upright MRIs, because the magnets tend to be not as strong as the magnets in other MRI settings. Like we want a 3T MRI, which gives us the best look at it. We do not need to do an arthrogram where they inject dye, but this is an MRI, and these lines, that's where the ACL is. So that's what the ACL should look like. A nice thick black signal from the top part of the femur, or bottom part of the femur, top part of the tibia. This is what an ACL tear looks like. So there's your thigh bone, shin bone, kneecap. This is the front, that's the back. So all of this gray stuff is where the ACL used to be before this patient tore their ACL. And actually part of the ACL is actually flipped up in here. So it's torn off the femoral side. MRI gives us a lot of information, and especially with the meniscus, because it is very common to tear your meniscus when you damage your ACL. So now we have a patient in the office. They've injured their knee. We've examined them. We got an MRI, confirmed an ACL. So now what do we do? So the things that we consider are their age, their activity level, ability to participate in the full rehab program, which is very lengthy and intense and requires a lot of input from the patient, and then any other associated injuries. So those are the things that we consider. So when we're thinking about this, a couple of things. When somebody tears their ACL, they come in with a swollen knee. We get an MRI, confirms an ACL. A lot of times the patient, the athlete, the parents, they want surgery the next day. But we don't do surgery on an angry swollen knee unless there is a reason we need to be there. We actually take time before surgery to do some rehab, let them get their mobility back, let them get their strength back, let the swelling go away. Because once we do this surgery, we fix it tight, we fix it strong, we start moving them within 2 days of surgery. So if they go in swollen and tight, they're going to come out swollen and tight, they're going to struggle. So normally you need anywhere from 2 weeks to sometimes 6 weeks, depending on the injury, until the knee is ready for surgery. But by waiting, it actually pays great dividends as soon as we're done, because we start you in therapy within a few days. So the things that we consider, type of graft, how we fix the graft, that's really more of a surgeon thing. What happens where we're taking the graft from, and then the surgical technique. Are we doing an isolated ACL reconstruction? Is there any meniscal pathology? Do we have to add anything else? There's a lot of talk about what's called an anterolateral ligament or an LET. They're both lateral ligament reconstructions to provide a little more stability for the knee, and there's a very select population that we use that in. When we go in for surgery, once we get their mobility back and we deem that they're ready for surgery, so then it's an ACL reconstruction, which means we need to make a new one for them. It's done as an outpatient, so they're home that day on crutches and in a brace. The recovery, I'll just go through in broad strokes. Most times they're on crutches for about 3 weeks after surgery. They are in a brace, which goes from above the ankle to the mid-thigh. And that's usually about 6 weeks after surgery. We judge that in PT. Once they have enough strength to remove the brace, the support of the brace, then they go out of that. They're working with physical therapy for about 5 to 6 months. They're working on motion. They're working on strength. We start them at low impact with a stationary bike, graduate to an elliptical, treadmill time doesn't start until month 4 or 5, and that depends on how their strength is, how their stability feels. And then the treadmill really is a transition like everything else. We start walking, walk to jog, jog to run. Running program is usually by 6 months. We don't let people do any pivoting, cutting, twisting activities till after 6 months from surgery, because we want to make sure the new ACL is strong enough to take that stress. And then we still got to restore all their biomechanics with the way their muscles are working together and making sure we got rid of all those deficits. Typically takes 9 months from surgery to when they're ready to go back to a sport. But we don't just do that by flipping the calendar. At the end, we do something called a return to play test, which is a functional test. And the therapists put them through a whole battery of physical maneuvers, measure it according to the normal knee, and then everything gets put together. And they have to be above 90 typically in order to be safe to return to their sport. Now, the reason that's important is because that is a functional test. By exam, they're usually stable, they feel good, they want to go back, but they may not functionally be ready there. So that test actually helps us identify any deficits that would put their knee at risk for re-injury. If we identify it, we can correct it. If we don't know about it, they may be at higher risk. And the vast majority of patients are going to go back to their sport in an ACL brace or a sports brace. So the grafts really, two main choices. Autograft is using your own tissues, and allograft is using cadaver tissue, which comes from somebody else. So generally 30 and under, we use their own tissues. We really prefer that. We get better long-term results with that. They get better function out of their knee. 35 and older, we generally lean towards the cadaver tissue because the knee changes over time and over decades. And if you're robbing Peter to pay Paul to make a new ligament, then that donor site may have some morbidity to it and they may struggle with the rehab. In general, 30 to 35 is kind of a watershed area. It's more of a discussion, see what their studies look like, what other images they have. You can use either one very safely there. The two main grafts that are used now are a BTB or a patellar tendon. We call it BTB because that's what this picture is right here. There's a piece of bone, there's the tendon, and then there's a piece of bone on the other side. So that's coming from right in front of your knee, from the bottom of your kneecap to your shin bone. The other popular choice is the quadriceps tendon, which is then above your kneecap, and that is typically soft tissue. Some surgeons do use the little piece of bone with that as well. They both work fantastic. And with the quadriceps tendon, whether you're using a piece of bone or all soft tissue, it works very well. Hamstrings really have fallen out of favor in general, except in the pediatric population. So hamstrings are still used with pediatric ACLs, which we're really not going to get into too much here tonight. Small subset are doing primary ACL repairs. Some centers are getting pretty good results with this. And then there's another thing called the Bear implant, which is basically an ACL repair. So arthroscopically, once we're in there, this is what we're seeing. If you remember that picture before where we saw the ACL and it was just going straight up and down, this is a torn ACL. This used to be in the back of the knee all the way up in the femur. So arthroscopically, when we're doing this, we need to get that out of there so we can put the new ACL in. We do an anatomic procedure, so we try to recreate the anatomy as best we can by putting the new ligament in. And I do have some videos at the end of this too. So overall, it's over a 90% success rate, depending on what you read. The success rate is measured by no instability and return to previous level of sports or higher. So high school to high school or college, college to college or pro. So the same level of sport or higher. There is a higher trend of failures in female athletes and higher failure with male athletes under 25 using cadaver tissue. So cadaver tissue used to be a lot more popular. We have some really good studies that show that the men under 25, they feel good, they go back too early, their mechanics aren't ready, and then they re-tear it. So we don't use cadaver tissue in young athletes. We really prefer using your own tissues. Just surgically, there's two general ways to do it. One is drilling right through the tibial bone and using that tunnel to go into the femoral bone, or I prefer this technique. It's two independent tunnels, so you can see this angles off a little bit. And that's important because that's a better position for rotational stability with your ACL. They both work very well, but this is kind of the preferred technique right now. There are a lot of surgeons who do this. We've seen decades of injuries, ACL injuries in the NFL. This is what most of their docs do. They get great stability out of that to get their athletes back. But it really is a surgeon preference. These are just pictures of an older technique using a screw and a metal screw here. On this one, not exactly in the right position. We actually want this screw back here. So tunnel position is very important. I find it much easier with that anterior medial portal technique to get that femoral tunnel exactly where we want it. And it can give you anterior and rotational stability. So this is just a post-op x-ray. Instead of coming straight up, it's coming over that way. So it looks like we're in nice position. So arthroscopically, this is what we see. This is an ACL injury. This is a right knee. The tibial side is not in bad shape, but the femoral side is torn. The knee was loose. So we have to clean everything out. This is all the way in the back of the knee because that's where the ACL goes. All this white stuff is what was left of the ACL. So we have to put our tunnel there to recreate the anatomy as best we can. This is a little guide pin in the shin bone. This is the footprint from the ACL. We want to be right in the middle of that when we put our new graft in. So that's the tunnel in the shin bone. That's the tunnel in the thigh bone. We really get back as far as we can with that wall because we want to be back as anatomic as possible with our graft. That's what an ACL reconstruction looks like. So the old ACL is out, new ACL is in, and we want to see a triangle between this ligament, which is your PCL, and your ACL, because that way we know we're not too vertical to provide the stability for the patient. Fixation, we really don't need to talk about. In general, we use interference screws or suspension fixation, which means it goes on the outside of the thigh and the outside of the tibia. In general, patellar tendon uses interference screws, mostly composite. Some people use metal, which is absolutely fine. Quad tendon is usually suspension fixation because most of the quad tendons are soft tissue. Again, some people use a bone plug and they use a screw with that. So this is, we're going to go through these quickly because we're up on 30 minutes. This is a diagnostic arthroscopy of a recent patient. So this is the cartilage under the kneecap. Cartilage should look pearly white. We look on the inside part of the knee first. So that's thigh bone cartilage, shin bone cartilage. This is your meniscus, which is the shock absorber of the knee. So even though the MRI looked okay, there's nothing, the closest thing to 100% is what we see with the camera. So we make sure that's okay. This is the stump of the ACL. Here's where it was torn from the thigh bone. So that's flipped to the front of the knee. So we got to get that out of there. And then we look at the meniscus on the outside as well. Same idea, thigh bone, shin bone. We want to make sure that's all nice and stable, nice and smooth. So then, let me get to the next one. So we clean out the ACL, make sure that stump is out of the way because we're going to put a new ligament in there. So we can't have that old ligament in the way. So we just clean it all up. And then we clean out the shin bone side and then the thigh bone side just to make sure the old ligament is cleaned out of there so we can get the new one in. And then this is after we've drilled everything. These are passing stitches. So there's the bone plug. We're passing that up into the thigh bone, into that socket that we created. We want to make sure we get it up in the right position, the right rotation, and the right depth. So we generally try to get the end of this bone plug as flush as possible with the edge of the thigh bone where we made our socket. So you see we get this and we push it up a little bit, make sure we get it to the right level. And that's about right, just a little more. That's it, right there, that's where we want it. And then we got to fix it into place with a screw on both sides. So return to play. So they've done this. They're going through the rehab. Again, it's about 5 to 6 months with a physical therapist. And then we get them in a sports performance realm at that point, doing a return to play program, which is higher level stuff. They're working on their speed, their power, their agility, their landing mechanics. What we want to see is full range of motion, full strength on manual motor testing, which they usually have well before 9 months. But then we do that return to play test, which really tests them dynamically. A bunch of different tests that they do with the therapist to make sure they have that muscle control to protect their stability. The minimum is 9 months. Trend is actually to go a little bit longer. We have really good data from the NFL that shows that returning before 9 months carries a higher risk of re-injury, about 20%. Every month you return after 9 months to your sport, it decreases about 10 to 15% per month. 9 months seems to be the best, but it's not always when they are ready. That's why we do that return to play test. And if they're not ready, they're not ready, because you don't want to put them back with a risk for a re-injury. So we do a functional screening for clearance, gives a functional assessment of the knee as well as the clinical assessment we have in the office by seeing them. And if we can identify any deficits that may put their knee at risk, then we can correct them, and then we get a better outcome, and then we don't need to see them again. So in summary, ACL injuries are very common, higher incidence in female athletes than males playing the same sports. That's high school and college. We need to address all the variable risk factors to attempt to decrease the incidence, regardless of the technique. Basically, if you put the tunnels in the right position, you fix the graft well, do the rehab, let them do the rehab, get everything back. The patient is committed to the rehab because we tell them, look, you have all the control. You can get the mobility back and you can get the strength back. Surgeon can't do that for you. The more work they put into the knee, the better it's going to be. And avoid cadaver tissue as a primary choice, especially in athletes less than 25 years old. And that's all I got. So we'll wait for Kristen to come back
There I
on, and we'll
am.
go through any questions that we got.
Awesome. I learned a lot, and I love seeing those surgery videos. I'm always not sure what I'm looking at, but it's always really interesting.
We kept the blood to a minimum.
Well, I don't mind that, but other people might.
No.
Okay, so we have did you say you don't?
No. Well, no, obviously I don't. I said I
I was gonna
know.
say, I hope you
Some
don't.
people don't. Some people don't like it.
All right, so we will get started with the Q&A. If anybody has any questions, you can pop them right in that box. We have a couple in there already. So we'll start with, if I trip and land on my knee, is there any risk to my ACL?
It depends on how, if like a direct blow to the knee from tripping and falling typically does not high risk for damaging your ACL. Usually it is a plant at speed. So you're jogging or running, you plant your foot and you rotate. That's typically how people tear their ACL, not from a direct blow to the knee. It can happen, but not as common.
Great. Oh, and do you want to close or stop the share on your screen? That way we can see your.
Oh, am I not there? All
Yep.
right,
No, you're there, but real tiny. There you
there
go.
we go.
Better.
How's
Better.
that?
Great. So next question, how do you determine to add an ALL with a high school athlete? Also, since females have a higher rate of re-tear, why isn't it automatically used for them?
So it's not automatically used because it shouldn't be. So it's not at that lateral reconstruction, there's a subset of patients you use it on. We usually use it in the smaller percentage of patients who've had an ACL reconstruction and have re-injured it, because we want to add something else to their knee as far as stability. We don't use it in everybody. The ones we do use it are if they have hyperextension. Hyperextension is a big risk. And if they have signs in the clinic of frank rotational instability clinically, then we consider doing that in a primary setting.
Right. That's it. We usually get some more questions, but here, popped up. What is your experience with the military population?
I've had a pretty long experience with the military because we're so close to McGuire, Dix, Lakehurst. The military population, obviously, they're very active. They do injure their knees and shoulders quite commonly. And when they have an ACL injury, these men and women tend to rehab pretty well because they're generally motivated to get back to their full duty, because not a lot of them like just being at a desk. And that they got to be able to, especially if they're active duty and they have to be able to deploy, their knee has to be in really good shape after any kind of surgical procedure to make sure they're safe to go back.
Keep them nice and stable. Okay. Is there a criteria that you utilize to determine your quad tendon grafts versus patellar tendon grafts? Do you see larger challenges with one versus the other?
No, they both work very well. Now, with the patellar tendon, we have about 40 years of good solid data. With the quad tendon, we have less than 10 years of good solid data. So both work very well. I'm comfortable using both. There are a couple of factors that we look at. One is how high is the kneecap riding on the thigh bone? There are some people who have a very high riding kneecap. It's called patella alta. And when they have that, you end up with a really long patellar tendon. So it's actually better to use the quadriceps tendon in those patients. If they have growth plates that are not fully closed, then we don't want a piece of bone across a growth plate that's not done closing. So the quadriceps tendon is the best choice for that. And then there are some other factors. Have they ever had anterior knee pain? Do they have any signs of a little breakdown or tendinosis in the patellar tendon on that side, in which case we would go towards the quadriceps tendon. And a lot of times in revisions, if they've had one side and unfortunately they re-tear it years down the road, we go to the other side.
Great. Where do nutrition and stem cell research come into play? I guess two different things.
Okay, so nutrition. Look, these are generally young, active, healthy people. So they want to make sure they're getting everything they in across the broad spectrum of nutrition. I mean, that could be a 15-minute talk. As far as stem cells, we haven't really seen a reliable role of stem cells in changing the outcomes of ACL reconstructions. Unfortunately, there's a ton of non-scientific information out there. And you have to be careful of what you read. I don't think they do any harm, but it is not part of our protocol in my practice or at our practice as a whole. And at many of the large centers through the country, that is not a typical thing to add. But certainly talk to your provider if you're thinking that may help you.
60 plus male, former college athlete seeking ACL repair. Is age a dismissive factor?
Arthritis is a dismissive factor. So people in their 60s are going to be much more likely to have arthritic changes in their knee. If you have arthritis, you want to be careful about having an ACL reconstruction because likely you have other damage that's been chronic inside your knee. And it may not be the right thing for you. Not everybody that's 60 and over that has an ACL tear needs to have surgery. Not every ACL needs surgery. You know, some of the factors that we look at is what's your activity level? Are you doing pivoting, cutting, twisting sports and activities? What does everything else look like in the knee? And how is your stability exam clinically? Because if your MRI shows a tear or partial tear in your ACL, but you have arthritis and your exam is stable, you don't need anything done with that. And arthritis is a stiffening disease, so that's the big factor. It's not necessarily the age number; it's the any kind of degeneration in the knee is a factor when considering a reconstruction.
While we're talking about reconstruction, the question is, when do you do repair versus reconstruction?
I really don't do repairs. I do reconstructions. There are some surgeons that really lean towards repairing them if they can. The issues with that is if you don't get that to heal and it's not solid and you got a high level athlete and they're going to put a lot of stress on it, I don't like things to fail. So
Mhm.
it's not one of my preferred techniques. And I think the vast majority of the people in our practice feel the same way.
Have you used synthetic grafts?
No,
Yeah.
that is a thing that was initially in the like 80s and 90s. They were trying to use Gore-Tex grafts, and I think they actually probably worked okay, but there's a reason that they're not used because there were some reactions to the tissue in there. But no, I do not use synthetic grafts.
Are you okay with blood flow restriction being performed with your post-op ACLs? If so, when are you okay with therapy starting BFR?
100% okay with BFR. It's a great technique to get the muscles back. You have to, the early phases of therapy, it's kind of hard because you have to get the muscles to start firing again. Especially the quad, if it's not firing, then BFR is not going to do anything for you. But once the quad is firing and you're getting some tone, I think it's a great technique, but it comes in and out as they're going through their therapy over 6 months with the therapist. They may do it for a couple of weeks, may not see it again for 4 to 5 weeks. But I do encourage people to use that. I think it is a very good technique to get the quad and the hamstrings tuned up a little bit quicker.
Great. I think that was it for the questions. Thank you so much, everybody, for joining. I have my contact information in the chat, and if you have any of your emails, you all have my cell phone number and my email. So if you have any questions, you'd like to schedule an appointment, you can always reach out to me and I will have our team get in touch with you. And I just want to say thank you so much, Dr. Salvo. I didn't know much about ACL. I feel like I learned a lot tonight.
Thank you, Kristen. I hope what I said was right.
Well, fingers crossed. Fingers crossed. I trust you.
It's working out pretty well so far.
Wonderful. Oh, wait, let me see. One more popped up. Oh, one more. We'll do one last one.
Yep.
6 months post ACL repair, is the lack of knee extension solely dependent on rehab, or does the repair method play a factor? There's no other issues.
So if you're talking about a repair or a reconstruction, if it's a reconstruction or a repair, 6 months is way too long to not have your extension. We check people at regular intervals because we want that full extension back by 6 to 8 weeks at the most. The quicker you get the full extension, the better the knee is going to move, the better the knee is going to work. At 6 months, if you're still have a flexion contracture, then you probably have a problem with scar tissue inside the knee, and maybe even forming something called a cyclops lesion, which is a big wad of scar right in front of that tibial tunnel in the knee, and it's a mechanical block. So, if they're that far out, then sometimes you have to go in arthroscopically, get that scar out of there, break up any other scar in order to get their mobility back. But we check them regularly, because if we start seeing them go down that path, then we talk to the therapist, talk to them, talk to their parents. So you really got to get this thing straight, or I'm going to get it straight.
Go see your surgeon.
Yep.
Okay. All right. Well, on that note, thank you so much, Dr. Salvo. I really appreciate it. And I'm sure everybody else does.
Thank you for setting this up.
Yeah. Have a great night.
All right. You too.